Welcome to today's Power of Knowing webinar, Whole Person-Centered Care. Understanding comes from knowing. The best care that anyone can receive is whole person-centered care. Today's webinar will explore this type of care, which considers the entire person, paying attention to their medical health, behavioral health, and social situation. This free webinar is part of a series called The Power of Knowing, created by Authoricare Collective, which empowers people to be active participants in their care journey, enabling them to live on their own terms through personalized support for mind, body, and spirit. To get us started, please welcome our moderator, Risa Hanau. Risa serves as clinical and community educator at Authoricare Collective and is also a member of the Cone Health Ethics Committee. She is a licensed clinical social worker. Risa, I turn it over to you.
Thank you, Paul. It is my pleasure to welcome our panelists for today's webinar. First, I would like to introduce Bob Cleveland. Bob has a long career in the field of aging. He started his career in his hometown of Rockford, Illinois, and then after moving to North Carolina, he has worked with the Piedmont Triad Regional Council Area Agency on Aging since 2012. He is an aging program planner where he works with county planning committees to allocate funding for services for older adults and their caregivers. Over the past few years, Bob has been serving on a team at the AAA looking for ways to collaborate with healthcare and insurance payers to address social needs that affect health. Our next panelist is Emilia Muse. Emilia holds a PhD and is the director of the Center of Excellence for Integrated Care for the Foundation for Health Leadership and Innovation. In her role, Emilia helps systems of all sizes and configurations make clinical, operational, and financial changes that are necessary to deliver whole person care. She provides training to equip providers and leadership with skills to implement and deliver integrated care services, as well as leading research and advocacy activities to improve quality and access for behavioral health care in North Carolina. Welcome. And Gail Scott. Gail is our Director of Social Work here at Authoricare Collective. Gail has over 25 years of experience in hospice and end-of-life care. She is expert in caring for patients and families and has a particular interest in advanced care planning. Gail is a licensed clinical social worker and has a master's degree in social work. Welcome to all of our panelists. I also want to welcome our participants. It's always helpful for us to get to know a little bit about you, and the best way we can do that in our virtual world is to make use of a polling question. You will see that polling question come up on your Zoom screen. It is multiple choice because we know that many of us fulfill many roles. So we may be a patient, a caregiver, a healthcare professional, human services professional, spiritual care guide. Please select any and all that apply to you. We know that many of us juggle many different roles at the same time and appreciate your participation. It will be wonderful when we get to the point where we can see each other in person and raise hands and get to hear about each other, but this is our way of doing it. So thank you for participating. And we will take a look. Wow, we have a tremendous number of caregivers, not surprising. And many caregivers are probably also healthcare professionals and human service professionals. And we welcome our patients and spiritual care guides. And everyone with us today. Thank you for joining us. As we begin our conversation with our panelists, I want to invite each of you as a participant to submit a question at any time with the question and answer area on the Zoom screen. We will try to answer as many of those as we can during our time together, and really want to hear your voice and your question during our time together. To get us started, Emilia, can you describe what whole person care is and why it's important to everyone, and what role your organization plays in trying to make it a reality for everyone?
Absolutely. Thank you, Risa, and thank you to AuthoriCare and all the participants for having me today. So whole person care is very much as it kind of sounds with this word whole. It's focused on being holistic, and that's inclusive of biological health, psychological health, social health, and spiritual health. And it also recognizes that health is much more than the absence of disease. It's a conscious pursuit of physical, emotional, spiritual, environmental, occupational, relational aspects of our experience as humans. And to achieve whole person health, we need lots of components to attend to all parts of our person. And so that might include medication, physical therapy, behavioral health therapy, surgery, spiritual counseling, but also compassion, presence, and connection from healthcare providers. So traditionally in Western medicine, which a lot of our healthcare system is based on, there was a very much an emphasis on the biomedical model, focused on the physicality of our bodies, what's going on physically, biologically. And whole person approaches address that, as well as all the other multiple aspects of people, all of their context, including the impact of trauma, the society and culture that we live in. So the impact of racism, discrimination, and injustice. And that's also a lot to put onto the healthcare system right now, as we're going through lots of transformations to better address whole person health and recognize that there are a lot of different pieces of ourselves that we need support with. And so to kind of narrow it down, I like to talk about a few examples about whole person health. One is a patient example, a person with chronic pain, and they experience worsening pain every year around the holidays. And maybe through conversations with their provider or some counseling, they come to learn that that worsening pain is because they have a lot of grief going on around the holidays. They miss some family members who have passed, and that time of year when it's all about family, fellowship, and gathering really makes them feel unwell emotionally, and that impacts their pain. And so I think a lot of us who have had pain, and maybe it's been worse with stressors, can understand how a psychosocial emotional experience such as grief can really impact the physical experience of pain. Another one, which I've seen working a lot in primary care and behavioral health, is this connection between depression and diabetes. So sometimes on the behavioral health side, with mental health care, substance use care, some people are working with community on depression, and maybe through lots of therapy services, depression is not improving. And that's because their physical health is not being attended to. And this could happen if they have undiagnosed or untreated diabetes, just really making their body feel really fatigued and ill. And they think it's a symptom of depression, but it's actually a symptom of something going on with them physically. And kind of on the positive side of whole person health is an example of someone going through a lot of social and medical stressors, say like divorce can be a very social stressor, and a chronic illness, or maybe a cancer, like a lot of physical healthcare demands, but they have a very strong spirituality and religious community to support them. And so given those social and physical stressors, they're actually doing very well. And so that's an example of how whole person health can work together for wellness. And in my role at the Center of Excellence for Integrated Care, we really focus on the integration of mental health, substance use, and primary care services. So mental health and substance use I usually refer to as behavioral health. And behavioral health, just to clarify and give context for that language, is the promotion of mental health, resilience, and well-being. It includes treatment for mental health and substance use disorders, but also supporting people who experience those disorders or in recovery for some of those conditions, along with their families and community. And in my work, we're trying to embed behavioral health care where people receive their physical health care. And there's been a lot of progress and improvement in where people are going in to get their flu shots, their annual exams, their diabetes follow-up visits. People are really starting to attend to all parts of people in those appointments. But we help establish some of those integrated systems and help clinics and practices embed a behavioral health provider into their primary care, or we work with mental health and substance use agencies to help them provide integrated services that are coordinated with primary care or other healthcare services. And so we really want to make it a reality for everyone that they can go somewhere and experience holistic healthcare in a medical home or a health home where they can walk through one door and receive support for physical illness, wellness, and prevention, but also their mental health, maybe risk for substance use, and social components as well, like housing, transportation, food, and lots of other things that they may need. We want it to be, everyone can access those doors with equity and come through that door and get everything they need in one place. So we're really trying to make that happen through our technical assistance, training services, and some of the advocacy initiatives that we have going on in our organization. But that's our vision of how we want it to happen. It's going to take a lot of work to get there. But as more people are learning about whole person care, we're going to get closer and closer along the way. And I think Risa is going to transition it to Bob now, who can talk about how agencies can make whole person care possible.
Right. Your information is really wonderful as the base for our conversation. Because if we think, Bob, about first to start with, what is an area agency on aging, so that we all have an understanding what is the purpose and the role? How do we go about finding an area agency on aging? And then talking to us about what is it that specifically you all are doing to help make the reality of whole person care really available and possible.
Sure. Well, thank you, Risa, and good afternoon, everyone. And I want to thank Emilia for that great introduction of whole person care. And so to answer the question, as far as an area agency on aging, we are established by the Older Americans Act, which was established in 1965, to really start to address the needs of older adults. Prior to that, older adults were largely in poverty. That's why Social Security was passed. And then there was a recognition that older adults really need more supports in the community. They need nutritious food. They need transportation because maybe they're not driving anymore. They need in-home care to support them so that they can age in place. And so area agencies were really established to set up regionally a supportive service network to ensure that people could, in a sense, as I said, age in place. So area agencies, they're all across the country, and here in North Carolina, there are 16 area agencies on aging, and across the country, there's 600 in total. So it doesn't matter where you go in this country, you are covered by an area agency on aging. We always say that when you've seen one area agency, you've seen one area agency, because they don't all operate the same way or offer the same services. Even here in North Carolina, where our area agency doesn't provide direct services, we help fund services in each of our 12 counties. But outside of that, in some of the rural communities, some of those area agencies do provide direct service. They are the meal provider, or they are the transportation provider. So, but overall, that's what area agencies are out there to do, to look at, do a survey of needs in the community and do what we can to help address those needs. You know, if mostly people are saying we need in-home help, you know, we need to direct funding in that area. Or we need rides to medical appointments, direct funding in that area. So that's what we do in terms of planning. In terms of what we are doing to address whole person care, I'd like to go back to a story that we heard a number of years ago, which really helped clarify things for us. And this was a story out of Greensboro. There's a woman who had, I believe, 4 to 5 different chronic conditions. So she had a heart issue, she had diabetes, COPD, a couple other health issues. And in 1 year's time, this woman made 130 some odd trips to the emergency department. They fixed her up and they sent her back home. Well, after a year, a group of doctors at Cone Triad Healthcare Network were reviewing this case, and they said, my goodness, you know, 130 visits, we need to find out what's going on with this woman. So they sent a nurse case manager out to the home. When she arrives, she finds that the woman has no electricity. And even if she had electricity, she did not have a working refrigerator. So what couldn't she keep cold? Well, her insulin for her diabetes. And so literally every couple of days, this woman is crashing, goes to the ER, they fix her up, and they send her right back home into that home environment that's not working for her, and that causes her to keep having medical issues. So the doctors group got together, and out of their own pockets, they paid for a new refrigerator for this woman, stocked with food, got her electricity turned back on, and they sent a nurse case manager out there to do some education with her and walk her through how to be healthier. In that year since, I think most people would be shocked to learn that that woman had no ER visits in that following year because those social needs were met. And so we asked the question, like, well, what did the doctors do? Did they do anything medical? No. They didn't do the medical piece. They helped her meet those social needs. And because those social needs were met, it mitigated her medical need. And so with that, you know, we in the Aging Network have been really looking to how can we better integrate with healthcare? How can we help healthcare so that we can meet that need of that whole person? So we're not just looking at what happens in the 4 walls of the medical office and the medical says, yes, I'm going to treat your diabetes or I'm going to give you this medication for your heart, but also what's going on at home. And we know that the physicians don't have that ability to leave their office and go, you know, we don't have the traveling medical doctor anymore. You know, that was back in the days of the Waltons where they made the visits. And they knew what was going on in that home. Those days are long gone. And so one of the projects that we're developing currently is community health workers. And these will be workers that when we get a referral, maybe from Wake Forest Baptist Health or Cone or any medical provider, it might be a free and charitable clinic, that someone needs help and they're having difficulty navigating maybe social supports or they just don't know what they need, we can send out a community health worker to work with them. They're there to go out, kind of assess the home, be eyes and ears in the home, because they may have told their doctor, I have this pain, I have this, but they didn't tell them about the hole in their roof that's now causing mold and causing their asthma issue. They may not have told them about the lack of a handrail and they can't get up and down stairs. So those sorts of things. And for just as a recent example, we had a woman call and say she needed a stair lift because she couldn't get her aging parent up and down the stairs. Fortunately, we got a call the very next day of someone who said they wanted to donate a stair lift. But those aren't typical things that you write a prescription for. So, you know, we're talking about how we can work with healthcare so that we can expand services and supports. And fortunately in our country, I think we've really started to turn the corner where just a few years ago, Medicare Advantage plans only paid for medical care. And now they're starting to pay for meals and transportation and adult daycare services because they're realizing the same thing that we all know already, is that these social supports are really critical to keeping people healthy. It's not one over the other, it's one and. You know, we need both the medical and the social supports and the physical, the behavioral health piece, the spiritual care. It is that whole person we're trying to address, not just one piece. And I think what happens when you address just one piece, we fall down. You know, we don't meet that need of that individual. As explained in that example, you know, once that social need was met, she didn't really need those medical interventions. Yes, you need to monitor that, but you don't need to provide, you know, 130 ER visits at, you know, $4,000 or $5,000 a pop. You're talking hundreds of thousands of dollars that were spent that really didn't need to be spent. And so we're also focused on trying to spread that message that community-based services cost far less than medical interventions. So again, we're not saying everything just needs to be about social. That wouldn't be right either. So we need the medical. You know, if I have something wrong in my body, I want to make sure that I have a medical professional be able to assess that. But oftentimes we've talked about having, in a sense, two roads. You have the medical road, which is very well funded, and you have the social services that have been more, I would say, minimally funded. Actually, in this country, we spend a lot more on medical than we do social, as compared to most other industrialized countries in the world. They're spending far more on social supports than they are medical supports. So again, that's the work we're trying to do with community health workers, is to get people actually in the home, to visit them, to work with them and support them, not just a one-time visit either. It's if they need ongoing support and connection to services, because again, we want them to be healthy, well, reduce healthcare utilization, but the end game is having more and more healthy people, more and more healthy outcomes.
Wonderful, thank you. I'm struck, Gail, as we turn to you as a hospice and palliative care expert and social worker. The reality of hospice care is that look at the whole person. Maybe one of the original methods of providing that type of care, but to a very limited population, those who have life-limiting or terminal illnesses. But it is helpful for us to understand, I think, on this topic of whole person care, why it is so important to have that perspective at a time of a life-limiting illness, and to learn some about the model of care that hospice utilizes, because I think it can in many ways inform our conversation that we've already had.
Thank you, Risa, and thank you, Emilia and Bob, again, for laying such a great foundation for whole person-centered care. And it is certainly an honor and a privilege to be with you all today. I do find it fitting that this particular Power of Knowing, focusing on whole person-centered care, is a topic for November, as November is National Hospice and Palliative Care Month. And certainly the foundation and core of hospice and palliative care is whole person care. As many of our participants today may know, hospice care is considered to be the model for quality, compassionate care for people facing a life-limiting illness. Hospice provides expert medical care, pain management, and emotional and spiritual support expressly tailored to the patient's needs and wishes. Hospice, however, doesn't just provide this care to the identified patient, but to his or her entire family or a support system of caregivers. So this again provides attention to the individual in his or her role as a mother, or a sister, a wife. There again, that whole person in many aspects or roles that they serve. The family is truly the primary unit of care in hospice. As we shift our focus in many areas of healthcare today to whole person centered care, one might say that hospice and palliative care has truly been ahead of its time. Hospice began in this country as a grassroots movement in the 70s by volunteers and begun by volunteers who were inspired by Dame Cicely Saunders, who was the founder of the modern hospice movement. And Dame Saunders emphasized focusing on the patient rather than the disease, and introduced this notion of total pain, which paid attention to the psychological and spiritual, as well as physical discomfort that one might experience at end of life. Saunders' practice and vision were informed by a whole person philosophy. She argued that traditional medicine and the traditional medical model of care didn't meet the complex needs of people at end of life, and that care must focus on the emotional and spiritual pain and struggles experienced, not just the physical symptoms. We do know that sometimes physical symptoms are evidence of emotional or spiritual pain, and it is through the attention that hospice provides counseling, support, and assistance in working through these areas that individuals experience relief and alleviation of suffering. Saunders, in her practice, embodied whole person care, as she herself was a nurse, later became a licensed social worker, and then was told that she could best influence the treatment and care of the terminally ill if she became a physician. So she was sort of a one woman or one person, whole person centered care provider. Again, hospice care is a holistic model of care. It meets the physical, the social, emotional, and spiritual needs of patients, their families, friends, loved ones, caregivers. And hospice and palliative care accomplish this through a team of professionals. The team comprises, or is referred to as, an interdisciplinary model of care. It's a team approach to care. And Paul, if you will, there's a slide I'd like to share that illustrates the team. And you will see that certainly the patient is at the center of this model of care, along with their family and caregivers. And among the interdisciplinary team is a hospice provider, attending physician or nurse practitioner who oversees and directs the care, guides the professionals, the registered nurse who works towards symptom management, addressing physical needs and concerns so that a person is comfortable, certified hospice aides who provide the personal care that is so important and often needed as individuals decline and are no longer able to have the independence in their care needs that they once had. Volunteers who provide respite, companionship, support. Social workers assist the patient and family in working through unresolved family issues, which oftentimes may occur or be in place prior to admission to hospice services, as well as counseling around changing roles and relationships, loss of independence. A spiritual counselor, or often referred to as a chaplain, as a member of the hospice team, who addresses spiritual distress or needs, there again providing support, prayer, comfort, whatever the patient or individual feels that would give them comfort. And bereavement counselors, who are certainly adept at addressing concerns related to loss, anticipatory grief, and the grieving process even after the end of hospice care. So hospice is a team approach to care, and inherent, as you see, the center of that team is a focus on the individual and making sure that that individual has the tools and the practices in place that promote their self-empowerment. A personalized health plan or plan of care is developed for each individual in hospice and palliative care. And this plan of care focuses on the individual's goals and the interventions that the team uses to help the patient achieve those goals, whatever they may be, as well as, and most importantly, self-determined life closure.
Thank you. What a wonderful overview. And I know that there is overlap and intersection as you were speaking, Gail. I know, Emilia, something came to your mind to add to our conversation. I want to invite you to do that.
Yeah, I just really love, Gail, what you shared about the team model for hospice care. I think is so important to emphasize when we're talking about whole person care. That is just like kind of like the Cadillac of health services, is to have a team working that cohesively together. I think is just brilliant. And I think hospice and home health care have really set that standard high and shown how teams can work really well. And from a patient perspective, I think we'd all be very lucky if all of our healthcare providers, social service providers would come to a team. Like if we had a therapist that's a lead on your mental health, your primary care provider lead on your physical health, maybe a dietitian helping you. When they all come together, they're, say, for example, Emilia's all-star health team. And I think that model that you showed, really when all the pieces come together, shows how that can be delivered. And it's really beautiful. And I hope it can be implemented across even more sectors of healthcare.
Thank you. And I want to remind participants, you can submit a question or if you have a comment that you would like to share with the panelists. But Emilia, I'm going to come back to you. You said something as you were getting us started about when we think about social determinants of health and the reality of individuals not all having access to care and services. And certainly that has become even more evident during this period of COVID. And I wonder if you could talk to us a bit more about the concept of seeking equity in healthcare for all.
Right. There's a lot of big work to be done there. It's been in existence for a long time, but the pandemic has highlighted for a lot of stakeholders and policy makers, and it's enhanced the disparities that exist in our healthcare system when it comes to access. That people, based on transportation, resources in their neighborhood, even down to grocery options in their neighborhood, don't have the same access to being healthy and being as well as possible as other people. And I think there's lots of levels that we need to work on there. But one of them is supporting people with finding access to healthcare coverage. And that can take a lot of different pathways, but I think that's the biggest barrier possibly that I consistently see across sectors of healthcare, is that people aren't able to access a health provider or a health team member because they have no coverage for that and they can't afford it out of pocket. So to boil that down to a really basic thing, we need to support people with finding ways to cover their health care or support programming to serve those people specifically.
Great. And so I can see again an intersection between the work that you do, that Bob does. And I want to dig a little bit more into that. And I also want to, Gail, come to you. There was a question very specifically around the concept of, as you mentioned, self-determined life closure. And Certainly autonomy we know is extraordinarily important for all of us. And as one's life is coming closer to the end, the concept of self-determined life closure, if you could talk a little bit about that and explain what that is.
Sure, I am happy to, and thank you so much to the participant who raised that question, because it also gives me an opportunity to speak to something that I had intended to say earlier when we were looking at the wheel, or the pie, if you will, the pie of the interdisciplinary team, and that is that certainly it is always the individual's right to choose what services or what members of the team that they wish to participate in their hospice plan of care, or to decline or refuse certain aspects of hospice care. However, we encourage individuals, regardless of whether they feel they may need a social worker or a spiritual guide or chaplain, to accept the entire team or accept the entire pie, if you will, because we find that people really receive the best and the best care that we have to offer when they do accept the entire team, when the whole team can work together as intended. And so certainly a part of self-determined life closure is patient rights, and a patient's right to make decisions or about who they wish to have participating in their care. Self-determined life closure may relate to where a person wishes to be in their final days of life, whether that be in their own home or in a hospice facility or inpatient unit, Beacon Place, or hospice home, which are the inpatient units that are served or a part of AuthoriCare's hospice services. Self-determined life closure may also be related to a person's right to make decisions about what medical interventions or assistance they wish to have provided or not. We often think about the importance of advanced care planning, and in the Patient Self-Determination Act, agencies that receive Medicare dollars are required to provide information about advanced care planning, the right to complete advanced care directives, living wills, healthcare power of attorneys, which speak to whether a person would want to have aggressive or life-sustaining measures at end of life or upon diagnosis of a terminal or chronic serious illness. So making those decisions a decision about who the person is one trusts to make decisions for them if they are no longer able to speak for themselves, is certainly a part of self-determined life closure. So the right to make decisions and to make one's wishes known is all a part of self-determined life closure. Not to mention what needs to occur, who do you need to see, what people do you need to speak to have closure or to experience closure in one's life, or all aspects of self-determined life closure.
Thank you. And Bob, we are talking certainly about the concept of whole person care. And so being able to determine for myself what that looks like and what I need, but then I also have to know what's available, or I have to know how to find what I feel like I need. And I'm assuming that a lot of your work at the area agency is tied into me saying, I have this need. How can you connect me to get my need met?
Absolutely. We get a lot of calls. Matter of fact, in most every county, There's a senior line or information referral line. And if they don't have, or that's not funded in their county, we have 26 senior centers across the Piedmont region. And as part of their certification, they must also offer information referrals. So anybody could call a senior center or an information line to find out about what resources are available to them. And Gail, you talked about advanced care planning, and that's certainly one thing that I've found in my many, many years of working with older adults or maybe even caregivers is a failure to plan, a failure to find out about resources before you actually need them. Many, many times I would get a call from a caregiver who said, Mom was taking care of Dad. Dad's got dementia, and Mom fell and broke her hip. She's in the hospital. So what do I do? And, a lot of people were used to dealing with emergencies, and we don't plan out to say, okay, what can I do for Dad, or what services do I need to have available should something happen to Mom? So that planning is something very important, and those planning services are available, again, in many counties, as we have something called information and options counseling. And that options counseling is specifically that. Let's sit down and talk about what kinds of things you need, what kinds of things you want to see happen. Because if you say, at the end of my life, I don't want to be in a nursing home, well, let's figure out how to make that happen. Do you have caregivers available to you? Do you have an insurance policy that might pay for in-home aid? Or do you need other community-based services that will help cover that in-home aid for you? So really to look at, what types of things are available, and there are professionals out there to help. And again, I think we've learned a lot, I would say, from the people in the disability community. They have a slogan that says, nothing about us without us. And so they're saying, hey, if we're going to be talking about services, I don't need you as a professional sitting across the desk from me telling what you think is good for me. I need to be included in that. And again, hearing their wishes, desires, to say, okay, yes, I want in-home care, but I don't want a stranger coming into my house. And certainly during COVID, we heard a lot more of that, where they're saying, normally it would have been okay to bring somebody else, but if I know an in-home aid is going to my home and somebody else's home and somebody else's home and somebody else's home, I don't know that I want that right now, because I want to be protected from maybe COVID passing around. And that could happen just even any other day. I don't want a stranger coming in. So again, I want my daughter to provide my care. I want a neighbor to provide my care. And so we're looking at options of how to make those types of things a reality, giving people options and letting them make their best choice to decide what's right for them.
Wonderful. And Emilia, I was struck by what Bob just said in terms of the patient's voice, the patient, the family. How does your organization bring the patient's voice into your work? Where we represent professional organizations, and yet we're talking about individuals. We don't want to focus on a diagnosis. We want to focus on the person. We want to focus on the individual needs, experience, past treatment that may have been received or not. So how do you bring the patient's voice into the work?
Right. We have a few, well, not a few, we have 21 kind of domains or standards that we look at when we're looking at implementing integrated care, whole person care. And a few of those speak to specifically inclusion of the patient and their family being however they define it, into their treatment for their physical and behavioral health care. And so we kind of come up with a consensus rating for how the practice and providers currently operate. And sometimes the inclusion is very passive, but we come up with a plan to help them very actively include the patient and family in decision-making and treatment planning, and kind of considering the patient and family context and resources. And then a couple other domains also speak to how active or passive a clinic or practice is in connecting patients and families to social resources. Because we know that handing out a list of phone numbers or brochures and asking patients and families to call and set up their own appointments is not very effective. And a lot of times our clients and patients won't make it to those appointments. We really want to wrap around the patient and family and have a healthcare team support or even make those appointments, and also make sure that the patient and family got those resources, like they got connected to transportation, housing, or a specialist provider. And so we kind of work with practices in a very detailed and direct way, like what steps they need to implement in their EHR and their workflows to progress in those domains.
And in HR, we're talking about an electronic health record, right?
Correct. Yes.
Great. So Bob, we've gotten questions about, you made mention of the options counseling. Someone's asking specifically about how that would be accessed in Guilford. In general, is the access through your organization? We're going to be sending an email that will have certainly the link and email to your area agency, but is it making contact with your agency or any other area agency where somebody might live and see if that service is available? Bob, are you able to hear me? I'm thinking that Bob might be having some technical problems. So what I will say is, for the options service, I would contact the area agency on aging. We're going to have the contact information in an email that we will be sending out tomorrow. But I also want to point out that certainly AuthoriCare Collective is a resource for education on advanced care planning. So if people are seeking assistance in completing advanced directives, living wills, healthcare power of attorney, and you are in our service area, we are very much available to assist. And many hospice organizations are as well. Hospitals also are often very much available. So we know that somebody has shared that options counseling is also available through Senior Resources of Guilford. And that is specifically for Guilford County. So that is great resource information, and we appreciate that. Thank you very much. Bob is continuing to try to get back on. He is having some technical difficulties, but I am being attentive to time, and I'm thinking, Gail, when we think about the intersection of the work that you and I have both done, we have lived in this very unique setting of really looking at the entire person. And thinking how helpful it can be if that were to be the model for all. If you had a takeaway message or kind of a final thought that you wanted to share with us, that would be wonderful.
Thank you, Risa. Certainly, in thinking about hospice care and whole person, I reflect back upon a number or many individuals that I've worked with over the years. And one particular case that comes to mind was a gentleman that I had worked with many years ago. I'll call him Mr. Lee, who was a custodian, and he had worked for many years, lived a simple life, and due to life circumstances, had a great deal of trust for many people due to his past personal experiences. He had lost his wife. He was a widower and also had the primary care for an adult son that he and his wife had adopted as an infant, and who had grown up with some some disabilities related to developmental delays, as well as some mental health concerns and addiction. And so when Mr. Lee was admitted to hospice services, he was very closed initially. And as he eventually gained the trust, or the team, his hospice team gained his trust, his primary concern was not on his own health or even management of the pain that he experienced as a result of his lung cancer diagnosis, but on what was going to happen to his son, who would be providing care for his son. So as a part of that whole person care and that attention to the issues and the circumstances that individuals find themselves facing really throughout life, that don't disappear just because a person is dying, the team began working very diligently with Mr. Lee on making arrangements, helping to establish a plan for his son's care. We were able to identify another family member, a distant relative, who Mr. Lee had maintained trust for, who was willing to become a guardian. Also, as it turned out, the son was a guardian for his son. And in addition, the son it was determined that he did have the ability to live independently with some oversight and guidance from the guardian. And so this enabled Mr. Lee to eventually agree to having his symptoms managed and leaving the home and dying at our hospice home on the Burlington campus of AuthoriCare. So it was attention to the many complex needs and concerns of the whole person and his role as a father, as well as a hospice patient. And I certainly would love the opportunity as well, just to share, to reemphasize how hospice does attend to the whole person, and to share the AuthoriCare Collective mission statement, which is: AuthoriCare Collective empowers people to be active participants in their journey, enabling them to live on their own terms through personalized support for mind, body, and spirit.
Thank you. That certainly does capture beautifully what we are speaking about. And we think that we have Bob back with us. When we think about certainly, the need of internet, the need of access to services in order to be able to communicate in this day and age, it strikes me that that is a tremendous need that we've all learned much more about. And I wonder, as we wrap up, Bob, if you were to leave us with a final thought or an encouragement of the utilization of the area agencies and the role that that you play for all of us in the community.
Sure. First of all, can you hear me?
Yes.
Okay. So yes, certainly the role that we play is we're looking at creating systems and systems of support. So one of the things we're always looking at is trying to look at new opportunities, new ways of reaching people or helping them connect, new services that may be needed. And just very quickly, as an example, when the CARES Act funds came out, we implemented a new tech training program to help older adults learn technology. I think for many of us, it's just intuitive. We pick up a smartphone, we know how to use it, right? Or we figure it out. But for older adults, we may have many of them that say, well, my granddaughter, my grandson, my son or daughter gave me this tablet and I don't want to break it, so I haven't even touched it. And so we wanted to create a program that's from the very beginning, here's how you turn it on. Here's how you use email. We'll set up your email account. So we worked with a company out of Georgia to create an 8-week training program just to walk older adults through the very beginning of that, to help them connect, because Especially during the pandemic, we knew that social isolation became a huge, huge issue. And many people aren't aware that social isolation takes a huge impact on your physical health. Some people may not, there's a study that came out that said being socially isolated has the same physical effect on your body as smoking 15 cigarettes a day. So pretty amazing. And so, you know, it was not only just people in long-term care facilities, we saw their health decline because they didn't have access to family. Same thing, people who were left in their homes who maybe they were getting a meal every day delivered by a home care, meal provider, and now it's once a week or maybe twice a week because they've limited that delivery system. They've also, you know, cut down on that socialization that senior had. So again, that's one of the things as area agencies, we're always looking at, you know, creative solutions to problems, and how can we help older adults, again, age in place.
Wonderful. And just as a final thought, Emilia, I wonder what your takeaway when we think about whole person care would be.
Mhm. I think I have two takeaways because I know we have a big caregivers group on here and a big healthcare professionals group. And for healthcare professionals, I would say in this movement, and some of us are really specialized and good at it, at looking at whole person care, we're using a systemic lens to look at physical, emotional, social, and spiritual health needs and wellness. I would say when we're implementing this in our clinics, we also need to take a systemic look at our healthcare system and our clinics and attend to clinical, operational, and financial elements of integrating care and whole person care, because it's going to take all of those pieces to put this all together so that everyone can experience it. Then I would say, you know, to all of us and to our caregivers and patients especially, really take some time to consider your own whole person health. If you're kind of learning more about this concept and digging in, think about your own, how you're doing physically, emotionally, in your relationships and spiritually, and talk to people who are taking care of you, whether it's your health provider, friends, family, others, about your whole person health. And kind of, you can even map out, you know, 4 boxes, what's going well and what you need support with, and kind of really consider your own whole person care.
Wonderful. This hour has gone by so quickly. I want to say thank you for your expertise, your information, and your compassion that you bring to this work. Thank you to the participants, everyone who has registered. We'll be getting a follow-up email tomorrow. It will have links for the organizations that we talked about, also a link for the recording of today's webinar if you would want to share it with others or watch it again. I also want to encourage everyone to keep an eye out for the Power of Knowing series. We'll be continuing into 2022. This is our last one for this year, but we encourage you to visit our website for Power of Knowing to learn about future offerings. And then also we have the recordings of all that we have done during this entire series. And with that, I want to close with a quote actually by Jane Fonda. And it says, "The challenge is not to be perfect, it is to be whole." And with that, I will say, wonderful conversation. And I thank everyone for participating. And I hope that we all have a safe and good rest of our day. Thank you so much for being with us.